All right, thank you for staying. You're watching Daybreak on Trust TV. Time for us to take a look at the World Malaria Day. Today, Nigeria joins the global community to observe the World Malaria Day. And World Malaria Day is an international observance commemorated every year on 25th of April and recognizes global efforts to control malaria. Globally, 3.3 billion people in 106 countries are at risk of malaria, and in 2012 malaria caused an estimated 627,000 deaths, mostly among African children. Now the theme of this year's Malaria Day is time to deliver zero malaria, invest, innovate and implement. Now today we have in the studio Mr. Chukuma Okoronko, who is the Director and Head of Surveillance, Monitoring, Evaluations and Operations of the National Malaria Eradication Program, with us in the studio. Thank you so much for joining us, Doctor, on the program this morning.
Thank you very much for having me.
Yes. To begin with, how would you describe Nigeria's response to this, I would say, age-long disease, malaria, that we've been dealing with over the years?
Nigeria's response has been, I'll put it, yes, they've responded well, but they are also hampered by a whole lot of issues. So while we've been making progress, and we've seen quite progress being made in control and elimination of malaria, we still have a long way to go. So yes, there is some progress that is being made, and I can give you some examples. For example, we have reduced prevalence, national prevalence, from 42% to about 22% as at 2021 using our MIS. Now that's something significant over a period of time. Yes, in terms of mortality, in terms of number of cases, we are still not there. So in that context, you will say, no, we are still having a whole lot of cases, over 60 million cases annually, and that has not really dipped. In terms of mortality, if we're looking at overall number of deaths, we still also are not there. But if we look at it in terms of ratio, comparing to the population, then we also have a significant drop in terms of mortality due to malaria.
Okay, there's a report here that says Nigeria recorded, out of the figure of deaths, 619,000 deaths documented globally. Nigeria recorded 31% of that number. That's huge. And Nigeria, in terms of money, loses $1.1 billion, an equivalent of 645 million naira yearly to malaria prevention. Yet, we still have this number of deaths. We still have so many people coming down with it. Why is that so?
Well, there are several constraints, and that's why, again, the issue of the team is quite apt. It's talking about innovate, it's talking about implement, it's also talking about invest. So have we invested enough resources to be able to control the disease in 36 days plus FCT? Are we implementing up to scale in terms of the interventions that we know work? Have we done some innovative work? Are there things that we can innovate? So these are the issues. Now let me go down a little bit to details when I talk about investment. Currently, about 2/3 of the states have some funding for malaria in terms of donor support. A third is just about beginning that support with the help of the World Bank and Islamic Development Bank. And that is through a loan that is given to the country. So for over 15 years, or let's just say 10 years, these 1/3 of states, 30 states, plus FCT, have not had any support. And with malaria, once you take off your foot from the brakes, there is a
When you say they've not had any support, you're talking about international support, right?
Exactly.
How about homegrown support? What are the governments of states doing?
Good. That is also part and parcel of our task. We've done that through a whole lot of activities. We've done advocacies at the highest level. We're engaging with the Governors Forum. We are doing a whole lot of things to make sure that also government puts its resources. And I can tell you they're also trying. For example, in terms of nets, in distribution of nets, they're also doing some counterpart funding. But I'm afraid, as you know, the economy is somewhat on the downturn, and there are lots and lots of competing interests. So, government could do as much as it could. And that, of course, has not been sufficient, unfortunately. Maybe not due to any fault of theirs, but because of the resources that's available to them. We're trying to think about innovative ways of doing these things and mobilizing domestic resources. Let me give you an example. One of the things we are doing as an innovative way of mobilizing domestic resources. In recent times, we have established what we call the Nigerian End Malaria Council. That End Malaria Council was inaugurated by the president himself and has a chair with Alhaji Dangote as a chair. I'm sure you're aware of that. And it's constituted of eminent private sector leaders. And we think by that we could be able to motivate, that we could be able to have resources from the domestic front, from the private sector, and get them also to advocate to government at the highest level to make sure that funding is made available for malaria at each state and at the national level, and if possible, at the local government level as well.
Okay, so talking about innovation here, you are talking about innovation with regards to, pooling resources to be able to fund some of these projects. But in terms of innovation as to, say, coming up with drugs or coming up with things that are things that will locally work for us as a country, what are some of the interventions or initiatives, by your organization?
First and foremost, there are standard interventions that have been proved to be effective and impactful for malaria, as far as malaria is concerned. One of it is the usage of just the nets, insecticide-treated nets. So once we use this consistently, it's already been proven to work. But the problem is first ensuring that it reaches everyone. What we want to achieve is the UHC universal health coverage as far as nets are concerned. Two, which is more important, is to make sure that people use them for what they are using them correctly and consistently. So that's one. There's another intervention that we could do, which has also proved impactful, but which is also difficult for us because of the financial outlay that is necessary to implement it. And that is the indoor residual spray. With indoor residual spray, you could crash the malaria burden in a very short while, but maintaining it is a problem. So the problem now is, where is the capital outlay to be able to implement IRS? I'm talking about the preventive aspect. Now there are other preventive aspects such as the seasonal malaria chemo prevention. Just shortly you were talking about children, and here is another thing. It's preventive, but this is targeted at areas or states where there are about 4 months of rains. So in those areas, that's why it's called seasonal malaria chemo prevention. So in those areas, what do? We distribute drugs, preventive medicines to children under 5 and try to make sure so that they stay safe. So by that, we are reducing, one, the severity of the disease and the possibility of them even having the disease. But more importantly is that we are reducing the severity and the less chance that they will also die from that disease. So we have these preventive measures. Of course, on the curative side, we also have our normal and routine case management issues. And these are the things that we are rolling across all the places. But there are behavioral issues.
Let's talk about the preventive aspect. You talked about the nets. Okay. In today's Nigeria, how would you describe the coverage of those nets? Do people in rural areas have access to these nets? And, how far would you say it has gone, and how available are these nets?
At the last meeting, at the last MIS, that's Malaria Indicator Survey, we discovered that over 50% of Nigerians use net.
Over 50, that means we'll have over 100 million people without the nets.
No, using. In terms of access to nets, we have something like over 60%. So access, there are two different things, usage. So in terms of access, more people have access. Incidentally, those in the rural areas are the ones that we prioritize, not even in the urban areas, because we have what we call subnational tailoring. We try to make sure that those in the most endemic areas, one, two, those who are unlikely to afford the nets, two, and then able to get the interventions that they require. But the problem is, of course, the usage. Those in the rural areas, incidentally, also receive from what we distribute in the urban areas, not by our knowledge, but because people like you and me who are living in the urban areas send what we have given to them. And incidentally, in some of these rural areas, they have more than enough that they tend to sell it.
Okay, let me just kind of derail just a bit. It looks like a derailment, but not exactly. We have situations where these nets that are being donated sold out on the streets. Are you aware of that?
There is a possibility. During our campaigns, we've had instances where we caught some people that were about to divert the nets. So there is a possibility. How does that work? Sometimes it works not by the fact that people who are distributing them, we try to put in stringent measures, including the ICTs. I mean, using ICT to be able to dictate to people that we are distributing to. We have that. So we can track every net that is being distributed at the time of distribution. So how do they get to the streets? The people who are given these nets also tend to sell them, and then there are people who want to make money. So what do? They go back to these people. Maybe they have 4, 6, 7, depending on what they say is the number of people in their households. We distribute based on number of people in the household. We try to cap it at 2. That's our 2 per person, 2 persons per net. And by the time we give, for example, a household of 4, of 8, and we give them 4, and they discover they have maybe 2 other old ones, and they are not using it, they tend to sell the other 2. They may even think that, oh, well, our present problem is hunger and not the net. So they tend to sell all of it in order to be able to meet their need at that moment in time.
Okay, so if they are selling these nets because they want to meet the needs, as you said, and in Nigeria today, people look at malaria and say, it's common malaria. The child is just having malaria. What is what is the ministry doing to really sensitize the people? Do the people really understand the severity of malaria? Because if we're recording this number of deaths, malaria is not common. Do they know that?
Exactly. I'm glad that also you are here telling me about that, when also we are also asking you to make sure that people know about it, because we rely not on ourselves, but on media organizations such as yours to be able to pass on this message. So we are trying as much as possible to highlight that fact. But you've made the point. 3 out of 10 people that die out of malaria is in Nigeria. That's a huge lot. And a quarter of people who are having cases worldwide is in Nigeria. Nigeria has the biggest burden as far as the world is concerned. And there are things that we, each and every one of us, could do. And that's part and parcel of what we are, part of the essence of World Malaria Day, to try to sensitize, mobilize, ensure that people understand that malaria is not common. That malaria is a killer. And one of the worst, the biggest killers as far as children are concerned, including pregnant women. Okay. In fact, there are 2 of those who are most at risk: children under 5 and pregnant women. And that's why we specially target them. And we try as much as possible to reach out with messages that they can that they know that malaria is not simply ordinary, that it can be.
Okay, let's talk about our capacity, still talking about innovation, our capacity to produce. So we talked about nets. We could also talk about the drugs itself in terms of production. What's our capacity like? And how much have we invested in our capacity to produce?
There are companies, one or two, that has the capacity to produce net in Nigeria. In fact, one of them I think is situated in the east. And there have been efforts to try and see how we can engage them and make sure they are able to supply for the country. But you know, it's a commercial venture. So, and are they only going to be dealing with government? We tend to distribute nets on a 3-year rolling basis. So each state, depending on the funding that's available, tend to get net every 3 years, as far as everybody gets the net every 3 years. So will they depend on that? Will they be able to survive on that? That's been one of the questions they've been asking. So that's an issue that we are dealing with, trying to see how we can engage with them to make sure that they can supply not only the government but also the Nigerian populace, be able to make sure that they also break even, because for them it's a question of profit.
Yeah, talking about profit, there are some persons that argue that the reason malaria has stayed and continues to ravage the public is because some persons are cashing out. There are some persons that argue that instead of us actually as a country looking for a solution or how to prevent it, instead we keep making new malaria drugs all the time. When you go to the pharmacies, you just see all sorts of different malaria drugs. So my question is, are we on the right track? Shouldn't we be looking at how to prevent rather than the production of all of these malaria drugs, which we see all the time?
Yes. First, let me tackle it from two sides. The issue of prevention, I've talked about it a lot and still want to emphasize on that. There are several preventive measures. I've mentioned about 3 already. And one is the SMC. The other one, of course, is the SMC that also deals with drugs and medicines. The other one is the ITN. The other one is, of course, the IRS, which I told you about, the capital outlay. So yes, it is still there. But people are still going to come down with malaria for whatever reason. Let me give you also another issue. We are seeing a kind of shift in the behavior of the vector, the mosquito itself. So what we are seeing now is, one, some form of, before they are more of indoor biting, but now what we are seeing is a gradual shift to both indoor and outdoor biting. So what do? We still need to tackle the outdoor while we are still tackling the indoor, the issues about the indoors. So we still have that problem. So people are going to come down with malaria, if not for anything, because of they have to stay outdoors. Again, issues about behavior comes into play. So the question now is, what do you do when you come down with malaria? So you need those drugs. But the question is, are we seeking, what's our health seeking behavior like? When we actually get to the health center and do we stick to the regimen as prescribed by the health provider? These are issues. So yes, there are politics, global politics around everything. But the issue is, have we done our own part?
You talked about the outdoor biting of the mosquitoes.
Yeah.
How about fumigation? Won't that help? Constant fumigation, that will not help.
To what extent? Let's just take the issue of fumigation. First, you have to look at the insecticide you are going to be using. Number 2, you have to talk about the coverage. Number 3, how do you prevent reinvasion in the area that you are fumigating? Who is going to be responsible for that fumigation? I'm talking about outside. The issue of indoor residual spray, which is something that we are saying that it is a good way to do. So if we do that, then we'll be able to make significant progress. But what you have touched indirectly is the issue of environmental management. That's what you've touched indirectly. And this is something that both the community and the government has responsibility for. Most countries that eliminated malaria did not eliminate it because they used actually the medicines, no, but because of environmental management. If we're able to do basic environmental management, make sure that roads are we have good roads where drainages work, so issues about water being stagnant somewhere, serving as breeding sites, will not apply. Good. People are able to, to clear their surroundings, make sure that these places, are not reservoirs, then we're in business.
Could this be the reason why we have predominance of this disease on the African continent and not in the developed countries like in Europe and the rest of them?
Sure, climate plays a huge role. There is absolutely no way. That's the essence of it. Where, I mean, there are when we talk about in mountainous areas, that's why if you look at, when we look at, if you research where you discover that we say that 97% of the population in the country, we didn't say 100%, are at most at risk, because there is a small percentage that live in high, elevated, very elevated areas where, as we know, mosquitoes do not breed in very cold areas. So in those areas where it's temperate, then we do not expect.
Is there a correlation to why malaria has lingered on the continent for so long? Between this, I mean, correlation between what we are just talking about now, not having prevalence of malaria in Europe, in other developed countries, and you have it more in Africa. You know, is there a correlation there? Because now recently, let me give an instance. Recently, Ghana was the first country to adopt the R21. I'm sure you are aware of that. Nigeria followed suit as second. And our R21 is a vaccine, malaria vaccine for children, basically. Now, there are talks about lack of funding. We all know where the whole innovation came from Oxford University. And now there are talks about the fact that since this innovation is not for use in developed countries, it's in Africa, this whole initiative is going to suffer from lack of funding and the rest of them. So do you see a correlation between, these environmental and climate issues and the reasons why, this issue is still more predominant in the African continent?
No, I will try to isolate issues about climate and the fact that the climate, gives that suitability for the breeding of the vector, and these other issues that we are raising in terms of interventions, because you are also going into interventions and the reasons for these interventions. So I would tend to pull them, not on the same scale, as it were, or not on, pull them on the same level. The fact that not just Africa, but also parts of Asia are also in the malaria belt, simply because of the climate. Now, what do they do, or what they failed to do, determines the burden of malaria in those countries. Unfortunately, in Africa, we have, and particularly in Nigeria, we have issues in terms of how we do our things or what we fail to do, and of course, in terms of resources that we have available also to do a lot of things that we ought to have done. So that's this. But for the vaccine, as we know, it's a good development. As far as I am concerned, actually there are now 2 vaccines available. This one is mentioned by Oxford, and then there is the RTSS vaccine, which already has been approved by the WHO. Incidentally, the one you've mentioned, the Oxford, has not yet been officially approved by WHO. Well, I'm sure that that's going to come up very soon. So we already have that. We already have a vaccine. But the problem is not just the cost, because again, there is Gavi has already indicated its interest to fund, countries to be able to, or assist countries to be able to procure the vaccine and to hopefully to distribute if they can mobilize some additional domestic resources. But the problem is also the production. As you remember, in the COVID-19, this thing, it started that way. And first, when they started with their own side before shifting to the African side. So now what they are doing is there is a production, because how many companies are currently producing it? So that is the problem. So what we are having as a challenge in terms of vaccine, for at least the one WHO has approved, is the issue of production. Nigeria is going to apply for about 100,000 doses between 2020 now and 2024. Now that is not even sufficient for one LGA.
So now that we know that we have this problem, and it happened, like you noted, during the COVID, where, of course, the developed countries, they funded the vaccine, of course, so it had to go to them first.
Exactly.
Now, malaria is our problem. So would you say that Nigeria has mobilized and engaged all its research institutes to see how they can come up with homegrown vaccine, or something homegrown, so that this issue of production, funding, and all of that will take backstage? Have we really utilized our research institutes, knowing very well that this is our problem, not that of the West?
I wish I could be able to address your question, because this is a policy issue. But I know that we have very sound research institutions. We have NIMA, quite a number of them. And at least the little we know is that they are also into that. But how far they have gone is something that we cannot say. How they'll be able to roll it out in the next, if they have gone significantly, is something that we are waiting to see. But the question is, have we funded these local institutions to be able to deliver on their mandates? Ab initio. That's a big problem. Research and development does not come cheap. People invest in it. Companies invest in it for long periods before it can yield something tangible. Then you can start talking about experimental studies, about field trials, and all. They don't come cheap at all. Have we been able to invest as a country in these kind of things? I believe that, not to me, but to all of us, and to those who are responsible for this.
All right, so on our part, let's talk about environmental management here. How do you preach environmental management to people in the rural communities where, the goal is just to have a shelter? It's not to have a serene environment. It's not to make sure, everywhere is, clean and everything. So how do you preach that? Because that's a very key component to the issues, where you have malaria or you have mosquitoes breeding, in an environment that they consider, quite habitable for them. So how do we manage environment really?
The basic issue for us is not necessarily first the message about environmental message, but first people's perception of malaria. She mentioned something about this, that people refer malaria as common. They think that malaria is something that they will have, their children will have. If they don't have it, it's abnormal for them.
So first, it has been normalized, sort of.
That's the problem. So we need to have a paradigm shift, and that's what we are working on. But of course, we are also telling them about the fact that they can do a whole lot. Take away your tires, those of you who have vehicles, and sometimes you take away the vehicles, the tires of the vehicle, and you dump them one side. They become breeding sites because water collects inside them. People who fetch water in the rural areas, as you know, when it is raining, they bring out their pots, and then water falls into them, or they even go to the stream, pulls the rainwater, pulls whatever they have done into containers, and leave it open. This becomes reservoirs. Or they leave their surroundings. It's not even a question of being dirty, but having reservoirs of water around them. So we try as much as possible to make sure that we encourage them to dispense of these reservoirs or cover them where appropriate. But first, if there's no change in mentality, change in behavior becomes difficult.
So, okay, today is World Malaria Day, and I do know that I'm sure there are lots of activities lined up to mark the day, and there'll be a lot of talk shops and all of that. After today, what happens? Is there any follow-up? Will the ministry continue sensitization? I mean, what follows up?
That's why the National Malaria Elimination Program exists. They don't exist only for World Malaria Day. They exist 365 days because they have activities and interventions to coordinate and implement with partners and stakeholders. So activities go on. We make sure that nets are being distributed. We make sure in distributing the nets that we also follow up with the right messages so that people understand why they should use the nets consistently and constantly. So we also have the SMC going on. We also have making sure that we distribute medicines that are supported by donor funds free of charge in the various health facilities in some of these supported states so that people can access them. We want to make sure that people take their children, once they develop fever, let them take that child immediately to the health facility. We want to make sure that people test. I want to emphasize that before treatment. Every one of us is guilty, maybe including some of us who are talking to me now. What do? They said, oh, I know this is malaria. I know it. So it cannot be malaria. But incidentally, they go and take, they've not tested, they go and take anti-malaria. And they feel all right. So they feel their self-diagnosis is right. No, it does not. We need to emphasize, and that's what we're emphasizing.
Is it possible that maybe because of how frequently people get this thing, that is why they don't go for tests anymore? I mean, some people treat malaria 3 times in a month.
Exactly, and that is wrong. There are 2 things that is a problem there. First, ACTs is the only line of drugs now available for effective treatment of malaria. If this fails, and we are seeing the signs, we're in trouble because we have to develop another line. So by the time people keep on treating themselves with this, we are in danger of
you just said something. You said you're seeing the sign that the ACT is failing?
Yeah, there are in some countries. We've had that report. In Asian countries, that is clear already. So, and we don't want that to happen in Africa. But we're seeing the signs already. The flags are coming up. In a few parts of Africa, that we are seeing some of these red flags. But fortunately, it has not happened, not significantly in the country. So by the time people keep on doing these same issues, doing this, we are in danger of developing resistance. Having this developing resistance. And that will be a problem. So it does not cost too much to test. And incidentally, 15 minutes, 20 minutes, the result of the test is out. Why will we keep on doing the same thing? I know also, again, I will come back to you who is talking to us because you also run adverts. And adverts by these manufacturing companies, drug manufacturing drugs. They said, oh, if symptoms persist, see your doctor after 3 days. Indirectly, what are they saying? They say, when you have...
Take the drug first.
Take the drugs first. Then, if symptoms persist, then you can go through the normal process. No, it does not work that way.
Exactly. So who is speaking about, I mean, who is speaking up against that to, the companies, these malaria, producing companies? Who is challenging them on that premise?
We are trying to speak to those companies, but more importantly, we are speaking also to I think it's the advertising practitioners, APCON or so, that is regulating advertising. We want to make sure that they understand the issues. We've spoken to them, but of course, certain things have not changed. So we are in the business of also sensitizing these companies as much as we can, but it's an uphill task.
Okay,
I can tell
so
you.
you talk about seeking tests, because I'm looking at how realistic and practical this is in our climate. We are in a country where we talk about access to health as a big challenge. You have people in the rural communities who cannot even do not even have access to hospitals. They cannot even, get medical practitioners, doctors to attend to them as at when due and all that. So do you see this as very practical?
2 things. One aspect of our interventions is the fact that in some of the places where we're talking about, in most of these places, malaria commodities are free, paid by the donors. When I talk to you about issues concerning funding our donor support, one of the areas of that donor support is the issue of provision of commodities free of charge to patients, to clients, especially those in those rural areas. So all they needed to do is to be able to make sure that they take their children or themselves to those facilities. And they are there. And we also have people that we've engaged, in quite a number of them, trying to sensitize the community that these are available. Of course, we know there are issues also of the logistic issues, where sometimes these may not be available and there are stockouts. So that also happens. The other thing, quickly, is the fact that we're also doing some experiment with medicine dealers, community pharmacies, PPMVs, all these ones, so that we see whether they can be able, because they reach a huge chunk of the Nigerian populace, they go to them. I said, why don't you give me mix something for me and I'll be okay. We're also trying to reach out to them. We are currently on a pilot project trying to see how we can first change the orientation of the PPMVs so that they can stick to quality of care. First, do some testing and then be able to give them the right medicine.
Okay, let's not also forget that we have people, for some reason, don't believe in modern medicine. They don't believe in these drugs that you're talking about. They would rather go to their herbal or herbalist sort of and get some concoctions there.
Traditional medicine.
Yes, and then maybe for some for some religious reasons, as a matter of fact,
Sure.
they don't think that they should take drugs. They should pray that God will heal them and the rest. Yes, there's a miracle aspect. God actually works wonders. But then, what do you say to them on a day like this?
I don't want to interfere with first religious beliefs, because religious beliefs can be held deeply and can be very personal. But we think also that they should also be able to look through and say to themselves, for example, do you leave your door open when you sleep in the night simply because you believe God can protect you? The answer is no. When you do a whole lot, do you say, okay, God will supply my need, and then you fold your hand and stay in-house and do nothing? Of course not. So there is always the aspect that you have to take care of yourself and then expect God or whatever you believe in to also to take care of yourself.
But you know, there are some people who take these traditional medicines,
I'm coming to that,
because
yeah.
they say, because they've lost faith in the orthodox ones. They tell you that when they take these tablets, they don't work, and that's why they went for those ones.
Sure, we've got a whole variety of reasons why people don't take medicines. Some, a whole lot, when they say it's a difference of why actually they do it. Sometimes they say it's because they lost faith. But most of the times, and we've seen that over and over again, it's a question of poverty. It's a question, well, maybe not poverty, it's a question of resources.
It's true, malaria drugs are becoming very expensive.
Yeah, so when you combine that together, expensive in their context, given where they are and what they think they need the money for, so it's in that context, it's expensive. So when you combine it with a test, now that's a little bit expensive. So they feel, I mean, I don't have to spend this money. I can use it for something else when I can easily take my traditional medicine and I will feel okay. And incidentally, they feel okay. But they don't know, they've only addressed the symptoms and not necessarily the basic issues. Right. And that's a problem.
All right, well, thank you so much for joining us on Daybreak. Really, very, very insightful perspectives on this World Malaria Day. Mr. Chukwuma Okoronko, he is the Director, the Head of Surveillance and Monitoring, Evaluations and Operations, National Malaria Eradication Program. Thank you so much for joining us on the show. We look forward to having you again for this sensitization.
Thank you very much for having me. Thank you for the interaction. But the name is Chukwu without the ma. So yes, I understand that sometimes it does happen.
Oh, okay.
And our program is an elimination program.
I beg your pardon.
Yeah. So thank you very much.
All right. Well, that's our show. Yeah, that's our show for today. In case you've missed, you can always catch up across all our social media platforms and also on our YouTube live stream. I am Ayuba Ilya. Thanks for watching. Join us again tomorrow.
Thank you for joining us this morning. Join us same time, same station tomorrow. My name is Stella Iyaji, and do have a very pleasant day.